الكثيري will cover in this section the basics of heart failure. The objectives are risk factors for heart failure, understanding the cause of left or right heart failure, the pathophysiology of signs and symptoms, clinical examination, diagnostic modalities, and the treatment. The heart failure risk factors are many, but these are the most important. The hypertension, the obesity, smoking, and diabetes. Because also we need to eliminate these risk factors in order to treat patients with heart failure. The cause of left side heart failure are into two categories. The first, called preserved ejection fraction, more than 50%, also known as the diastolic dysfunction. The idea in this category is the heart is unable to fill properly during diastole, so less blood is ejected during systole. The examples are hypertrophic cardiomyopathy, hypertension. Long-standing hypertension can cause concentric hypertrophy of the left ventricular walls, the restrictive cardiomyopathy, pericardial tamponade, and constrictive pericarditis. The other category is reduced ejection fraction, less than 40%, also known as systolic dysfunction. The idea here is the opposite. The heart is able to fill properly during diastole, but during systole, the heart is unable to eject the blood properly into the systemic circulation. The examples are dilated cardiomyopathy. This is a familial disease where the four chambers of the heart is overstretched. Arrhythmias can cause it, and the myocarditis can cause it. One of the major manifestations of left side heart failure is pulmonary congestion. When the heart is unable to eject the blood forward into the systemic circulation, the blood will pile up into the pulmonary circulation. And the manifestation will be dyspnea, shortness of breath, paroxysmal nocturnal dyspnea, shortness of breath after a period of time, orthopnea, shortness of breath when lying down, crackles can be appreciated by stethoscope, and the heart failure cells. The heart failure cells actually, when the microvascular system of the pulmonary system is ruptured and the blood leaking into the alveolar air sac. This is the heart failure cells. As you can see, this is the alveolar air sac, and the blood, these are the blood consumed by macrophages of the lung. Another manifestation is decreased systemic perfusion. As we know from the renal physiology, if there is low blood flow toward the kidney, the juxtaglomerular apparatus will sense the low blood pressure and will secrete renin. Renin will convert angiotensinogen into angiotensin 1, from angiotensin 1 to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 will do two things. First, will cause direct vasoconstriction of blood vessels. The second thing will lead to secretion of aldosterone from the suprarenal gland. Aldosterone will cause sodium and water reabsorption. So all these changes will exacerbate the heart failure. So one of the mainstay treatment of heart failure is ACE inhibitors, so we can block this process. On physical examination, there will be bilateral basilar rails on stethoscope, laterally displaced heart epics on palpation, and coolness and pallor of extremities. Right side heart failure, actually the most common cause is the left side heart failure. The idea here, if this is the left side of the heart, and this is the pulmonary area, and this is the right side of the heart. If there is left side failure, the blood will go backward into the pulmonary circulation and will end up eventually on the right side of the heart. Another cause also is the left to right shunt. This is the four chambers of the heart, and there is left to right shunt, for example, caused by VSD. This will lead to increase in pressure into the right side of the heart. Another example is chronic lung disease, such as COPD. COPD will lead to pulmonary vasoconstriction, so the heart needs an extra work to overcome this hypoxia and vasoconstriction. Eventually will lead to right side heart failure. The signs and symptoms are related to the structures which drains into the right side of the heart, such as jugular venous distension. On inspection you can see it. Hepatojugular reflux on palpation. When you palpate the abdomen, you can see the jugular vein distend. And painful hepatosplenomegaly on palpation, and dependent pitting edema, bilaterally in the lower limb, and nutmeg liver, also known as cardiac cirrhosis. These are the signs and symptoms. This is the jugular venous distension. This is the pitting edema, and this is the nutmeg liver. As you can see, these small dots, dark dots, these represent congested veins. The diagnostic test for heart failure is the chest X-ray. You can appreciate the pulmonary edema, transthoracic echo, also brain natriuretic peptide. This is secreted from the right atrium. An over-distended right atrium will lead to secretion of this peptide. An ECG, you can appreciate if there is left ventricular hypertrophy or pericarditis. This is the X-ray. This is the boot-shaped heart. This is the cardiomegaly. This is the pulmonary edema. As you can see, there's an obliteration of the costophrenic angle, representing the pulmonary edema. The treatment, the first and the most important, is the lifestyle modification. We need to eliminate the risk factors that we mentioned earlier in this slide: smoking cessation, weight loss, and salt restriction. The treatment, drugs that improve the prognosis and mortality and morbidity are the beta blockers, ACE inhibitors, aldosterone antagonists, and hydralazine. It is important to note that we must avoid the non-dihydropyridine calcium channel blockers with beta blocker, as they cause a complete heart block. Drugs that improve the symptoms are the diuretics and the digoxin. If all other medical treatment are failing, we can use biventricular pacemaker. This is the last option of treatment. The complication will be acute decompensated heart failure, cardioneural syndrome. There will be rapidly deteriorating in the glomerular filtration rate in the kidney, cardiac arrhythmias, and hepatic cirrhosis. Thank you very much.